It's like a short circuit. You bypass the receptor layer. I think PIK3CA is a big variable here. And earlier this morning in a conversation with colleagues, I was just mentioning about PIK3CA. So what is the PIK3CA is, of course, the PI3 kinase pathway, PI3 kinase, AKT, mTOR pathway, is a downstream signaling pathway for HER2 or the entire epidermal growth factor receptor family, okay? And so as a homo and heterodimerize, they signal through either the MAPK pathway or the PI3 kinase pathway. And these are major signaling nodes, potent pathways that activate transcriptional programs that actually result in resistance. Now, when you inhibit the receptor layer with potent therapy, theoretically you shut off the signal from the membrane, and then you shut off the PI3 kinase pathway. However, an activating mutation anywhere along that axis in the PIK3CA, in the AKT, or activation of mTOR would result in activation of that pathway, and you bypass. It's like a short circuit. You bypass the receptor layer, and now you inhibit all you want on the surface. It's not going to work. Actually, in the grant that you mentioned, we showed that actually if you treat tumors with pure anti-HER2 therapy, without chemotherapy, that have a PIK3CA mutation, there are, in our neoadjuvant trial, not a single one of those patients achieved a pathologic complete response with a combination of lapatinib and trastuzumab, which is just pure anti-HER2 therapy, which tells you that that type of mutation essentially shuts off or bypasses the inhibition, the potent inhibition of HER2. Therefore, as Dr. Shaughnessy mentioned, there is really the issue of, if that is there, how are those patients going to do on maintenance, right? Because you're not having, okay, you might have given them some chemo, which should not care or should equalize, but we still know that they respond less to chemo, less to TDXD, less to CDK4/6 inhibitors, right? So are we going to see similar outcomes in those patients or not?